Let me go to the next model, the medical home. A patient-centered medical home is, this is a delivery model, but to which there's attached a payment reform model. The delivery model is to restructure the primary care practice so that it's working as a team in a more patient-centered approach that involves proactive care planning, care plan development, and using data to manage care. In Minnesota, medical homes are referred to as healthcare homes. There's going to be a little theme here that the terms used in Minnesota are different than the rest of the country, consistently. So it's healthcare homes in Minnesota, it's medical home mostly every place else. The payment model, there are many payment models for medical home nationally. Most commonly, insurance companies or employers are making supplemental payments to practices each month to pay for infrastructure for the practice to operate as a medical home. The biggest piece of infrastructure is usually having a nurse care manager within the practice who's focused on the highest risk patients within the practice. Who are the high risk patients? They're patients usually have multiple chronic conditions and who are at significant risk of hospital admission within the next 12 months. In Minnesota, this monthly payment is referred to as a care management fee. There are some medical home programs across the country, and I've been involved in designing and implementing a couple that also offer a shared savings opportunity to the primary care practice. So if the practice can reduce the costs, the total costs for the patients attributed to that primary care practice, then they get to share in them with the employer or with the insurer. It doesn't appear that these arrangements are commonplace in Minnesota, but they do exist in some other states. I want to give you another example of an employer success, Hill Air Force Base. So the Department of Defense decided to pursue medical homes big time beginning in 2009, and they worked on a tri-service medical home project. In Utah, at Hill Air Force Base, they did this first and most aggressively. They had really impressive results. They saved, on diabetes care alone, they believe $300,000 a year. They took what was annual significant growth in their medical expense and actually brought their spending down as a result of having done this with lots of improved performance. You can see a 77% improvement in blood sugar control for diabetics. So there are examples, I'm going to sprinkle them throughout, of employers who have taken action. Sometimes they're public sector employers, sometimes they're private sector employers. And frankly, whether you're a public sector employer or a private sector employer, you have the same problem here in trying to manage your health benefits expense. There's really not much difference. I want to give you an example of another private employer action. I am working right now with 3 Cleveland area employers who have been led by Progressive Insurance. Progressive has a corporate medical director who believes passionately that payment reform is necessary to drive delivery system reform. And so these 3 employers have agreed to work with a large health system, and they're going to fund nurse care managers, or they're calling them care coordinators, to support their employees and dependents. If the health system's practices become recognized nationally as being medical homes. They've agreed that beginning in a couple of years, they are going to have a shared savings incentive for the health system. So they're going to measure changes in utilization and cost. If there are savings, they're going to get split between these 3 self-insured employers and the health system. Tim Kowalski is the corporate medical director for Progressive, and you can read his words here. He clearly believes with passion that this is necessary if Progressive is going to see better value in its healthcare purchasing. And I'll note the other 2 partnering purchasers. One is a manufacturer. The other is a local school district. And so they've come together. Yes?
How does this differ from the HMO model?
Quite a bit. So this is a strategy that focuses on what's happening in the primary care setting. Frankly, to employees, they have no idea that it's going on. In an HMO, traditionally, you would tell an employee, you have to enroll in this health benefit plan, and you have limitations in terms of who your providers are. Maybe you have to get approval to go get a service. This is all a change that's occurring within the delivery system in the primary care practice. Now, the patient might experience something differently, but their benefits are not impacted at all. And in fact, for these 3 employers, I think they all uniformly only have PPO design. So let's talk about medical home in Minnesota, or healthcare home. The development was sparked in 2008 by some state legislation. As of a few weeks ago, the Department of Health had certified 214 healthcare homes across the state that together serve 2.5 million Minnesotans. The Medicaid program in Minnesota, operated by the Department of Human Services, offers care coordination payments of $10 to $60 a month. Now, unlike in the medical home payment programs, or the one in Cleveland that I just referenced, and in fact most of them across the United States, the payments are only made to practices for those patients with chronic illnesses. So if you've got a patient who doesn't have any chronic illnesses, no diabetes, no asthma, no hypertension, there's no payment made. So the payments here are higher than what they are in many other states because of the fact that they're focused on high-risk patient population. There are some health plans in the state that are supporting this. And I'll note that as of now, there's no evaluation on the impact of healthcare homes in Minnesota, although there are some at least encouraging signs, as you can see here from this finding from the Health Partners Research Foundation. But we don't know yet whether this is saving money and improving quality. We don't know definitively. So the pros and cons of medical homes. The pros are medical homes help develop capacity where we probably most need it to manage quality and cost, which is in primary care. We are the most specialty-focused health system in the world. Most health systems across the country have a far greater percentage of dollars flowing to primary care. We are all about specialty care in the United States. Yet who manages services and manages resource utilization and can best manage quality? It's the primary care practice. So the pro here is that we're making an investment in where we need to have foundational strength, which is the primary care practice. If there's a shared savings model, there's an explicit incentive to reduce costs. Now, some believe that medical homes, even without that explicit incentive, are going to reduce costs. But if the practices have a shared savings incentive, then they're going to be focused more on costs, quite naturally. The use of performance measures, and usually it's public performance measures, keep the practices accountable. And there are many insurer and provider self-reported positive ROI findings. The cons are, well, this focuses only on the primary care practice. And while it is playing a foundational role, there are a lot of other players, including specialists and hospitals, that aren't directly engaged. There's not a lot of evidence yet of return on investment in the peer-reviewed literature. This is the PhD researchers who publish in journals. So we have a lot of health insurers and employers who are saying, hey, we saw great results, but we haven't seen a lot of that yet from the research community. This payment model does not address the fee-for-service volume incentive. Let me move on to bundle payment.